everybody, and welcome to MedSynapse podcast series. I'm your host, Nikhil Shah, and I'm thrilled to bring you yet another insightful session today where we explore the pivotal topic in pediatric health. Today, we'll be focusing on type 1 diabetes in children, a crucial subject that continues to challenge healthcare. And to help us navigate this topic, we are honored to have with us Dr. Nikhil Shah, again for the second time. Dr. Shah is a highly respected pediatric endocrinologist and a specialist in child and adolescent growth. With an extensive background, he has gained unparalleled experience of more than a decade now. Doctor has numerous publications in his high impact national and international journals, making him an invaluable voice in this field. So welcome back, Doctor.
Hi, Hetwi. At the onset, I'd like to thank Hetwi and MedSynapse for inviting me again. I think today is World Diabetes Day, so nothing more apt than discussing a topic which is very dear to me. I've done a lot of work in this topic, published a lot of papers to create awareness regarding type 1 diabetes in children. So yeah, thank you for inviting me.
Yeah, that's rightly mentioned. It's World Diabetes Day today, so it's the right time to talk about this topic. So now to start off, doctor, could you tell our audience, is diabetes very common in children, and what are the different types of diabetes that usually occur in children?
So there is a common misconception that people assume that diabetes happens only in adults. I think that's a very, very big misconception. Diabetes is very common in children, and the incidence is just going above every year. Unfortunately, not a lot of common man knows about this. Even doctors do not know about this, that diabetes can happen in children. So yes, diabetes is very common in children. Now, coming to the second part of the question, which is what are the different types of diabetes in children? The most common type of diabetes in children is type 1 diabetes. More than 90% of cases of diabetes in children is because of type 1 diabetes. Now, what is type 1 diabetes? So, type 1 diabetes is a chronic autoimmune condition where in certain genetically susceptible individuals, some environmental triggers are responsible for the production of antibodies, and these antibodies lead to the destruction of the beta cells of the pancreas, leading to insulin deficiency and then subsequent diabetes. Uh, uh, I was just looking at the numbers the other day, and there are around 12 lakh children in the world with type 1 diabetes, with 1.5 lakh children getting added every year. And I think there is no prizes for guessing who is number one in the amount of new cases as well as existing cases in the world. India has the maximum cases of type 1 diabetes, new as well as existing cases in the world. So we are number one in that. So I think it is important that we educate people regarding this. Now, what are the other types of diabetes? What are the other 10%? Type 2 diabetes, which we are seeing on the rise over the last few years because of obesity and metabolic syndrome. The other rare forms of diabetes included the genetic forms, which are like monogenic diabetes, neonatal diabetes, which happens under 6 months of age. So even children as young as 1 month and 2 months do get diabetes. The other forms of diabetes are MODY, that is the maturity onset diabetes of the young. The other rare forms of diabetes are because of drug-induced drugs like steroids, L-asparginase, pancreatogenic diabetes, which happens secondary to chronic pancreatitis. And in some conditions like cystic fibrosis, thalassemia, we do get to see diabetes. But I think today we'll focus more on type 1 diabetes, which is the most common form of diabetes in children.
I think that is so insightful and so rightly mentioned that type 1 is so very common, and it is not really sometimes it's not it is difficult to even diagnose. So the next question is, can you tell us more about how healthcare professionals or even parents might differentiate early signs between the two?
So I think how do we pick up type 1 diabetes? So what are the signs and symptoms? It's very difficult for a common man to pick up because I'm saying so many of the doctors are missing it out. I think the earliest signs that you'll get early on in the disease is something called as polyuria, that is increased frequency of urination. Polydipsia, where the child feels very thirsty, just drinking much more water. But in a hot country like India, people attribute it more to the heat. But you'll see sudden increase in thirst, sudden increase in urination. A child who was not bedwetting is suddenly started bedwetting because of the excess amount of urine that is being passed. Child feels hungry very time, which is something which is called as polyphagia. Another important thing is weight loss. So a drastic weight loss of say around 3-4 kilos over the last 2-3 months, or failure to gain weight. in a growing child, failure to gain height, unexplained fatigue are the common early signs and symptoms of type 1 diabetes. Uh, However, we rarely pick up children so early. They usually present to us with a very life-threatening, serious complication, which is called as diabetic ketoacidosis. So, what is diabetic ketoacidosis? Is when the sugar readings get very high because of the hyperglycemia. It leads to some metabolic consequences. That is the production of ketone bodies as well as metabolic acidosis, which causes destruction of all the body's tissues. And the symptoms during that time is what children typically present with are vomiting, pain in abdomen, difficulty in breathing, acidotic breathing. They come in shock, sometimes with seizures, loss of consciousness, and even we've lost children because they've not been picked up in time. So as I've explained, type 1 diabetes can mimic a lot of conditions. So if they just present with increased urination, people assume that it is a UTI. So, people are treating for the urine infection, but no one's checked the sugar. Pain in abdomen, people think of a surgical cause. Fast breathing, people think it's asthma or a pneumonia. So it can mimic a lot of conditions. So I
Mhm.
think in any unexplained condition, where the child is not improving, we should keep a high index of suspicion and just check one sugar. Even if we check that sugar, I think we should be able to pick up diabetes.
Right, that is so rightly mentioned. And I think that early intervention can make a big difference in management as well.
Yes, 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 definitely.
So now, how is type 1 diabetes diagnosed in children, and what are the main tests and protocols that are usually used?
So first, how do we diagnose diabetes? The definition for diabetes remains similar. So any symptoms of hyperglycemia, that is high sugar readings, as I explained to you, increased urination, increased drinking of water, with a sugar of more than 200, is characterized by diabetes. This is then confirmed by a fasting sugar. So any fasting sugar more than 126, or a postprandial sugar more than 200, confirms diabetes. HbA1c more than 6.5 also says about diabetes, but HbA1c should not be used as a standalone marker in children. It should always seen in relation with the sugar readings, because you can get false positives in children. Now, coming to type 1 diabetes, it's a very clinical diagnosis, but the confusion usually happens when you have to distinguish between type 2 diabetes. So, type 1 diabetes usually happens in younger children, type 2 diabetes happens in adolescents. Type 1 diabetes will usually present with decay. Type 2 diabetes do not frequently present with decay, that is diabetic ketoacidosis. Type 1 diabetes are thin, type 2 diabetes are obese children. There is a strong family history in type 2 diabetes, type 1 diabetes, not so much. Associated comorbidities like hypertension, dyslipidemia is seen more commonly in type 2 diabetes. Uh, Acanthosis, that is blackish discoloration of the neck, the axilla, is commonly seen in type 2 diabetes. So this is how we clinically differentiate between type 1 and type 2. Now coming to the question where you asked about the tests. So what we frequently do in these children who come to us with diabetes is the blood sugar levels, the HbA1cs. Once we know that it is diabetes, we send the specialized tests. A C-peptide test is usually done to understand the beta cell reserve of the pancreas. So usually type 1 diabetes children have a very low C-peptide indicating a very low beta cell reserve. However, in early detection of these cases, you might get a normal C-peptide. So the confirmatory test that we do is sending of the antibodies. So there are five antibodies that we check for type 1 diabetes. There is a GAD65 antibody, that is the glutamic acid decarboxylase. Then you have the zinc transporter 8, insulin antibody, insulin associated antigen 2 antibody, as well as the islet cell reserve antibody. Yes, so ICA antibody, that is.
I think
So any of
these.
these antibodies being positive tells us it is type 1 diabetes.
Okay. So does these tests differ from the ones that are used for adults?
So no, for if type 1 diabetes is suspected in adults, then we do send the antibodies. So it's pretty similar. But adults usually present with type 2 diabetes. Children
Mm.
usually present with type 1. But
Mm.
now we are getting a lot of mismatch and a lot of overlap. So adults are also presenting with type 1.
Mm.
Children are also presenting with type 2. So that is where we have to be very careful. So that's where the clinical differentiation along with the labs helps us to guide the diagnosis as well as the management, because the management is completely different in both the diseases.
Right, and I think that is so much clear for me as well, and it actually underscores how important and timely diagnosis is.
Yes, yes.
So now, once diagnosed with type 1 diabetes, how should children be managed? And could you share some of the most effective approaches that has evolved in recent years?
Whenever I talk to any patient who's recently diagnosed with type 1 diabetes, what I explain to them, it is like the four pillars of management of type 1 diabetes, or it's like the four wheels of a vehicle. The four wheels being glucose monitoring, insulin therapy, exercise, and a diet. If any of these wheels are not running properly, your car is not going to go. So, similarly, if you don't check the sugars, you don't know what insulin to give, how much insulin to give. If you give too much or too less insulin, again, it can lead to very increase or decrease of sugars. If you don't exercise, sugars can go haywire. If you eat anything, sugars can go haywire. So these are the four pillars I would like to talk over the next 2 to 3 minutes. So first and foremost, being glucose monitoring. I think that is the paramount and the most important step in type 1 diabetes. We need to check the sugars. In a resource limited country like India, the most common way of checking blood glucose is something called as the SMBG. That is the self monitoring of blood glucose. That is basically checking the glucose by using the glucometer. So basically, glucometer is a machine. So we prick the blood and it just gives us the sugar immediately. This is the capillary blood glucose. So in a day, at least it is advisable to check the blood glucose levels 6 to 10 times a day. So you have to prick the child so many amount of times. If it is not possible, then we at least expect him to check 3 times a day. That is pre-meal. So depending on the meals, you can give the insulin. It is very cost effective. It is easy, not very complicated for the parents. But as I said, it is cumbersome because you have to prick so many times in a day. Now, is there any better system? Yes, there is something called as the CGMS. That is the continuous glucose monitoring system. So this is a technology-driven world now that we have come in, and this has made our life very easy. So basically, what is the CGMS? Is basically a sensor which is there, which is present, which is attached to the arm that sends information to the reader. And basically, when you get the reader in front of the sensor, you directly get the sugar readings. This solves the problem of not tricking the child. Uh, the sensor keeps sending the sugar readings depending on what sensor we're using every 1 to 5 minutes. So you're getting a lot of information. The more information we get, the more data we get, the better we get in management. So slowly, we are moving to something called as CGMS. It is very effective because you're solving the number of pricks. However, it is very expensive. The current CGMS costs anywhere between 5,000 to 5,500 for 14 days. So yes, that's the challenge we have because of the cost. Majority of our patients are mostly on the SMBG. Now coming to the second part, that is the second pillar or the second wheel, that is insulin therapy. Uh, this is where I want to make one point clear that insulin is the only therapy which works in type 1 diabetes. No form of oral medicines, no form of alternate medicines work in type 1 diabetes. So you have to give insulin to the child. If someone is telling you that this medicine is going to work, that alternate therapy is going to work, it's all a lie, it's all a myth. No form of therapy except insulin works. Insulin has been discovered more than 100 years. It's been a century since the discovery of insulin, and we are yet using insulin. Only the mode and the types of insulin has changed, but the treatment is still the same. So in insulin, what we are using the regimen currently is something called as a basal bolus form of regimen. So the name itself tells us about the therapy that is basal and bolus. So what is the bolus? Bolus is basically a type of insulin which we are giving before the meals to cover the sugar rise before the meals. So it is either a short-acting insulin like the regular insulin or a rapid-acting analog insulin like the Lispro, Aspart, or glulucine, which we give before meals. But now, what happens to the sugar readings in between the meals and at night? So that's where we give a basal insulin. That is a long-acting insulin like glargine or digludic, which works over 24 hours to keep the sugars under control. So every child of type 1 diabetes is going to be in a minimum of 4 to 5 injections per day. That is what we have to explain the parents that this is going to go on for life. We cannot, do anything in management. They have to follow this. Coming to the third pillar, exercise. Like any normal child, I would advise 1 hour of exercise of moderate to vigorous aerobic activity. So, what does aerobic activity mean? Means some form of walking, cycling, swimming. Anaerobic activity is not routinely advised because it leads to high sugar readings. So, a lot of these adolescent boys want to go in the gym, pump up weights. We tell them no. Focus more on the cardio. That is much more important because that helps to get down the sugar levels, it helps to control the sugar readings. And the fourth pillar is diet. Uh, Diet now should be culturally acceptable, socially acceptable, acceptable to the needs, psychological and cognitive needs of the child. So what we form is a diet plan depending on the family with the help of the nutritionists, with the help of the diabetes educators. It has to be a well balanced diet having appropriate portion of carbohydrates, proteins, fats. We teach them something called as carbohydrate counting. So depending on what they're eating, how much is their sugar. So for example, depending on the size of the idli or depending on the size of the rotis, we teach them that small size roti will have so much carbohydrates, the medium size rotis will have so much carbohydrates, the vegetables will have so much carbohydrates. So that is the insulin they have to take. So these are the four pillars that we usually teach the patients, and this is what I think is the management of type 1 diabetes in a nutshell.
Right. I think also there are so many what do you call changes coming in the that have come in the recent years. But
Yes,
also, as you rightly mentioned, that type 1 diabetes can only be prevented, not prevented, just managed by insulin. That is the one major
correct,
drawback
correct,
of this
correct, correct.
disease.
So
So
we are expert at managing it, but unfortunately, as I mentioned in the definition of type 1 diabetes, still we don't identify those triggers. That cure is yet not reached for type 1 diabetes, and we
yeah.
are not able to prevent it yet.
So I think that is one major drawback as well and setback as well. So while managing HbA1c levels is very challenging in pediatric patients. So what are the main obstacles you usually encounter in optimizing HbA1c targets, and how do you balance the goal of tight glycemic control with the risk of hypoglycemia?
So at the end of the day, children are a very unique subset of population. They are children at the end of the day, so they are going to want to eat. They're going to want to eat what their friends are eating. So keeping all in mind, they are very unique in the way that they're completely dependent on the caregiver. They have to follow whatever their mummy papa tells them, whatever the people at home tell them. So I think the foremost important in optimizing a glycemic target is teaching the parents and the caregivers how to manage the condition. And as I said, the first and foremost, the most important is by checking off sugars, that is glucose monitoring. If we don't check sugars, you are not going to know how much insulin to give. And as a result, if you give too less insulin, the sugars can go high. You give too much of insulin, the sugars can drop, and this can lead to a haywire of the entire HbA1c. Uh, Second thing is following the modern forms of insulin therapy. So that is the basal bolus regimen, 4 to 5 injections per day, instead of the obsolete two injection technique that we used to give few years ago. So couple of decades ago, all our patients used to be on two injections, that is a split mix regimen. But what we realized, all those patients were developing complications very, very early. So now, no longer in any good center are any children with type 1 diabetes on two injections. They are on 4 to 5 injections per day. It is very important to counsel the parents that this is what it is. We need to give 4 injections per day. Coming to it, how do we optimize this technology? I think checking of sugars, insulin therapy, and main is use of technology. Technology has been a lifesaver in type 1 diabetes. So use of CGMS. CGMS, instead of pricking the child, the continuous glucose monitoring is giving you so much data. It tells you the trends, what is happening during the night, when the child is sleeping, when the child is exercising. So if you feel that during exercise, the child's sugar is dropping, you might have to give a short snack that time. You feel the child's sugar is dropping at night, you can accordingly adjust the doses. So CGMS has been a real lifesaver. Uh, and slowly, that's the reason now the world is moving from the glycemic target of HbA1c, because HbA1c tells us an average over the last 3 months.
Mm.
So that average can go a bit haywire because if you have too many high readings and too many low readings, the average might just normalize. So it doesn't tell us about the glycemic variability. So that's why the CGMS has come up with a new glycemic target called as time in range. So what is time in range? Time in range basically tells us the amount of sugar readings or the percentage of sugar readings which are maintained in the normal range. The normal range being 70 to 180. So the target that we expect our children to have, and so the glycemic target for HbA1c used to be 7. So for time in range, the target is 70%. So 70% of the readings should be between the target of 70 to 180. That means 17 hours in the day, your sugar should be in the normal range. If a child achieves a time in range target of around 70%, you're doing a great job. I think technology, again, now what we're having is the second part of technology that I need to talk about is something called as CSII, that is continuous subcutaneous insulin infusion, that is the insulin pumps. And they are another game changer device, uh, because in the form of, I think this is the closest we've gotten to an artificial pancreas. The closed hybrid loop automation device is the insulin pumps. So what does this insulin pumps do is the sensor is there. The sensor sends the information to the device, and the device itself is secreting the insulin. So when the sugar level drops, the pump
Mhm.
stops. It doesn't secrete the insulin. When the sugar
Mhm.
level increases, the pump automatically corrects and gives off the insulin. So these insulin pumps, recent insulin pumps, are really, really changing the entire management of type 1 diabetes. But the only drawback is the cost. They cost a bomb. They're expensive. So yes, it's yet for a resource limited setting country like India. Yeah, we are struggling.
That is really insightful, and we hope over the years the cost also reduces and we have much better
Correct, correct, correct.
options as well. So now one last question would be, what is your approach to involving children and adolescents in their diabetes plan in a way that fosters responsibility without overwhelming them?
So, as I mentioned earlier, children are a very unique subset in that early childhood is a very important time for establishing salutative and adaptive health behaviors. So, if you set good habits at that time, they will sustain you for life.
Mm.
So, that is the most important thing that we need to teach newly diagnosed children with type 1 diabetes about good habits. But before that, I think in a country like India, we need to teach the parents about acceptance. They have to accept the diagnosis till they don't understand that this is going to stay for lifelong. The child is going to require 4 to 5 shots a day. We are not going to be go ahead to teach them other things. So we have to be empathetic. We need to counsel them. Take the help of a psychologist if required. Get parents on board. Once they accept, the second thing that we need to teach them is discipline. As I was telling you, proper meal timings, proper meal habits, not snacking in between, regular exercise. It is very, very important to follow discipline. Third important thing is try to involve the children as early on in the care of type 1 diabetes. It can start with just selecting the finger, which finger to choose for pricking of sugars, selecting the side to, give the insulin, and slowly, slowly teach them how to, check the sugars or monitor blood glucose levels, teach them how to give the insulins so that they get independent as soon as possible. Let them manage the readings, let them ask their doubts to the doctors, so get them involved in the care of type 1 diabetes. It is very important because at the end of the day, they are living with the condition. They need to be taught about it. And finally, I think as doctors, we need to be empathetic with them. We need to understand that it's a lifelong condition. At the end of the day, they're children. So we can't be strict with them every time. You need to give them certain leeways. So give them cheat days. At the time of the birthdays, they can go and have a cake, but take that extra shot so even they can enjoy once in a while. Don't be like Hitler every time, ki why the sugar ratings are not correct, why this is not there. We try to understand the family, so accordingly we can adapt the care. I think one thing that I've learned over practice is that no one rule, no one protocol is there for all families. Every family need to adapt accordingly. Some families might want to follow this, some families might not to follow this. So I think as a clinician, as a doctor, we also need to be open and empathetic to whatever inputs they are giving. So I would say be empathetic, try to make them as disciplined as possible, and try to get children involved in the care as soon as possible. So yeah, these are the things I would really advise all my families.
Yes, I think that is such good advices, and also it also depends on how the family is actually taking it, or even how
Yes.
the uh, young kid is taking
So
it. So
one
building
thing I've
confidence in them is also key, I say.
one thing I've realized is children are very resilient.
Mm.
They will accept whatever the parents will tell them. So if we can get the parents on board, and all our parents do get on board, some take a little bit longer. But once the parents are on board, the children can manage themselves beautifully.
Mm.
Children are very, very resilient, much more resilient than adults. So it's, I think, just training the parents to get used to it, make it a part and parcel of life. It's like how we get up and brush our teeth daily. It's okay. You have to check sugar and give the shots. That's it. It doesn't take more than 2 minutes a day. That's all you need to take care of.
Yeah, that confidence is really necessary, I
So you have
would
to keep
say.
giving them that confidence every time.
Yes.
It's okay. You're doing well. Appreciate the hard work they're putting in. Keep motivating them because it is difficult, but we need to keep motivating.
True, true. Because at that age, they will actually follow what parents are saying. So,
Absolutely correct.
getting the that confidence for parents is really
Correct.
important.
One more thing I'd like to tell is what we notice is uh, people hide about these conditions. So they should
Mm.
not hide about about this, the more we tell other people about it. So the school authority should know, the friends should know. So the minute you tell them, even they start taking care of certain things. Otherwise, they are unnecessarily given like sweets and chocolates. So at least care is taken from that initially. So be open. It is not something like a contagious condition कि if diabetes है तो दूसरे को फैलेगा. It's not like that. They just need to be open and get motivated about it.
Right, that is rightly mentioned by you. Now, as we wrap up today's session, Doctor, it has always been an enlightening journey to have you with us. So, thank you so much for sharing
Thank
your
you so much.
knowledge and practical advice on type 1 diabetes in children.
Thank you so much for having me. Thank you to you and the MedSynapse team for carrying out this great work.
Thank you so much. And to our listeners, thank you for tuning into this episode of MedSynapse podcast series. And remember, if you're a healthcare professional who's eager to delve deeper into medical topics or have questions, do not hesitate to join us on the MedSynapse platform. MedSynapse platform is not just a resource, it's a dynamic space where you can connect with your medical peers, participate in meaningful discussions, and contribute to the ongoing evolution of healthcare. So until next time, stay safe and stay healthy.